Okay, I wanted to spend a little more time on the perception of pain before we move on to the parts of somatosensation that we initially skipped, like proprioception and balance. Those will be the next topic after this pain one. Now, we already hit on the receptors for pain. Those are the nociceptors, and we saw that some pain signals take the fast, myelinated pathway up to the brain, while others, for like that second lingering pain after the pain, they take the slower, unmyelinated pathway up to the brain. But now let's talk about pain more at the level of perception. So first off, pain is not just a simple direct signal from nociceptor up to the brain. Obviously, it can be that. Like when you hit your funny bone or feel a bee sting or whatever, in those cases, there's a pretty straightforward process from the nociceptors up to the brain, and you pretty straightforwardly will experience that pain. But that's not always the case with pain. So, for example, we'll see how pain can be affected by your mental states. Pain can occur with no stimulation to the skin, so no nociceptors involved at all. We'll see that pain intensity can differ based on things like your current attention or how you're distracted. And things like phantom limbs will actually show that pain can be, we might say, central as well as peripheral in origin, meaning the central nervous system rather than the peripheral nervous system out in the skin. And we'll come back to that one in the next video. But I want to start with an important insight about the nature of pain perception that was first proposed back in the 1960s, which really revolutionized pain research. It's called the gate control model. And it's a model, a physiological model, explaining some things that we've probably all experienced, like how rubbing a painful area or even an itchy bug bite can temporarily relieve that pain or that itching feeling. The gate control model, it doesn't undermine the basic pathway we talked about previously, going from nociceptors up through the spinal cord to the brainstem, through the thalamus, up to the parietal lobe. That's all correct. And in fact, understanding that fast pathway and the slow pathway for our somatosensory information is going to be fundamental to understanding this gate control model. So the basic idea here is when nociceptors are sending pain signals up to the brain, like when those C fibers, right, the slow type, keep sending a lingering pain signal for a minute or two after you bang your knee on the desk, during that time, other input seems to be able to modulate those signals, kind of like opening or closing a gate to block off or amplify the pain signal from getting through. So in one memorable formulation of this, a Dutch researcher around that time actually argued that there's a general principle in somatosensory wiring where fast blocks slow. What we mean here is fast signals, the ones taking that myelinated pathway, fast signals block slow signals. So touch signals, for example, will block those slower C fiber type of pain signals, the dull continuing second pain, but not block the initial quick bit of pain that goes through the A delta fibers, because that's also fast. Likewise, we know that itch uses those slow C fibers, so touch, going through the fast wires, can also turn off the slow wire itch temporarily, which is why it might help to temporarily do some activation of the touch receptors around the area where a mosquito has bitten you. Here's actually a picture giving a somewhat simplified version of the gate control model in terms of neural connections. So this would be like neurons happening out in the peripheral nervous system, or right when it's coming into the spinal cord from out there in the in your arm, for example, or somewhere in your skin. So the reality might be a little messier than this model, but this is roughly how it seems to work. This will give us the idea of it. Imagine you're following the somatosensory wires that go from your forearm, for example, in to your spinal cord. So coming from the forearm out here, they're going into the spinal cord, and then they're going to go up to the brain. You've got some C fiber nociceptors, but also maybe in that forearm around the same place, you've got a bunch of mechanoreceptors out there too. So now the basic pain pathway for C fiber nociceptors it could be thought of as just sort of the bottom bits of this diagram here. So out in your arm, you've got some nociceptors. They pick up a pain signal and they send the signal in, and it's going to go on and get transmitted to the brain, transmitted by a transmission cell, just another cell, another neuron that'll pass the signal on, again, going up to the brainstem, through the thalamus to S1, and then you feel the pain. Okay? So that part should make sense. That's kind of the way we've thought of it already. But you'll notice that when the nociceptor fires here in this little diagram, it also branches off and has an excitatory connection, a little plus here, meaning an excitatory connection to this other extra green neuron we see here, an excitatory neuron. Okay, well then when the nociceptor turns on, it turns on this green neuron. And when the green neuron turns on, you can see it also has an excitatory connection to this transmission cell. So in other words, it also pushes the blue cell to fire, make it more likely to fire, to send the pain signal onward to the brain. So far, nothing weird here. This would make sense. It seems kind of unnecessary to have this bit, but everything here kind of makes sense. Your nociceptor is activated. It makes it more likely for this cell to pass the pain signal on to your brain. But notice along the top of this diagram, we've got something else going on here. Here we've got signal coming in from those mechanoreceptors that are also in nearby parts of your skin. But interestingly, the mechanoreceptors, despite being not pain receptors, they have an extra connection here going off and branching and connecting to the pain system, connecting to the pain wires. So those mechanoreceptors have a hookup, in this case, to this red neuron. And the red neuron has an inhibitory connection. That's what that minus sign means. So it's got an inhibitory connection to that transmission cell, meaning if the red neuron gets turned on, which will happen if the mechanoreceptors are stimulated, then it'll turn off the transmission cell. It'll inhibit it. It'll make it fire less. So when the mechanoreceptors have activity, in other words, if you're touched near the place where the pain is happening, it could have a net effect of actually turning down this transmission cell. In other words, turning down the pain, inhibiting the pain signal that's going to the brain. So for example, imagine someone flicks you on your forearm really hard. Ouch! Like an A delta fiber will send a quick, immediate pain signal, the first pain, and you will certainly feel the flick. That's the first pain. You can't avoid it. But now, as that second pain kicks in and continues for a while, right, the lingering pain, you start to rub the skin where you were flicked. That activates the touch signals, meaning the mechanoreceptors sending their signals up the fast pathway, and we know fast blocks slow. What we mean here is the fast signals will be firing enough, they'll fire kind of more relative to the nociceptors, that they'll turn on this inhibitory connection and actually shut down or at least turn down that transmission cell, turn down that pathway. So they have an inhibitory effect on the nociceptor pathway. The slow C fiber type of pain signals end up getting blocked because it's kind of like the gate is closed, or at least it's not open as wide. So you'll end up feeling less pain than you would have without rubbing the place where that person flicked you. We've probably all experienced this way of minimizing pain. And this is actually used therapeutically these days with what's called a TINS unit, which stands for transcutaneous, so outside the skin, just mean electrical stimulation outside the skin. So transcutaneous electrical nerve stimulation is what TINS stands for. So electrical stimulation, just with these patches you put on the outside of the skin. So the electrodes activate the fast pathway neurons, which means it closes the gate, and the pain signals, the slow signals, don't go through as easily. Fast blocks slow. Importantly, there is one element of this diagram I haven't mentioned yet. If you look at this diagram here, there's this connection coming in from the central nervous system. In other words, signals coming down from the brain through the spinal cord. So in they have purple here, the central control, that's the brain. The brain can also inhibit the pain pathway from firing. So for example, when you're told by your dentist to expect a little pinch as the needle goes in, your brain can actually send an inhibitory signal down to that pain pathway in the spine, closing the gate. at that point the needle will poke in, but you'll feel less pain than you would have otherwise. So this introduces a bit of a complexity to the whole bottom-up perceptual process, where normally we think of perception as starting at the receptors and moving up to the brain for processing. But it turns out the brain also can send signals down to the peripheral nervous system in ways that can kind of turn up or turn down, amplify or reduce or filter activity from that sensory system. So when we talk about the straightforward path from receptor up to the brain, that's often described as a bottom-up process, a bottom-up sensory process, or the bottom-up influence on our perception. But there are also what we would call top-down influences or top-down processes, which can include the literal signals from the brain going down to the gate control neurons like we just saw, but also can include things like we talked about at the start of the course, where our past experience and our knowledge or our expectations or the current context or info from our other senses can all have some influences on what we perceive, what we experience, such that our perception is not determined solely by the pattern of activity down in the sensory receptors. Our visual illusions actually gave good examples of this, where what we perceived was not determined solely by the proximal stimulus that was impinging on our retinal cells in our eyes, but instead was influenced by these other factors too. So let's see some examples, some example research about top-down influences on pain. First, there are expectation effects. For example, when surgical patients are told how much pain to expect before a surgery or after a surgery, like in recovery, they actually self-administer less pain medication just because they're told how much pain to expect. So it seems like they're actually experiencing less pain, and that's why they use less medication. Likewise, in a more controlled setting, we can do lab studies on pain. So for example, in a 2011 lab study, experimenters applied a painful heat stimulus, always kind of the same level of painful heat. And what subjects did through these conditions, they rated their perceived pain in 4 different conditions. So the first condition, in a baseline condition, they only had saline injected into their skin. So they had an IV hooked up, but there was just saline, just empty salt water, no drugs, no pain relieving drugs, no analgesia or anything like that. The patients knew it was just saline, and during this baseline, they applied that painful heat stimulus and asked people, what is your pain rating? Like from 0 to 100, what's your pain rating? And the average is 66. Okay? Then in the second condition, what they did is they secretly gave these people a pain drug, an analgesic. It was injected through that IV, but the patients didn't know that the drug had started yet. They still thought it was just saline. They thought they were still in the baseline condition and the treatment hadn't started. And when asked what their pain level was, it was a bit lower at this point, which suggests the analgesic works. That's good. Pain drugs should have some effect on our pain, hopefully, because we use them all the time. But then, here's where it gets interesting. In the third condition, they were then told the drug was being injected. Now, it had already been injected. There's no change here between the second and the third condition in terms of what's actually in their body. So there's no change for the actual analgesic drug itself, but now they just know it's there. They're told it's there. They're expecting the drug to be there, so they're expecting their pain level to go down. And when they're asked, sure enough, their average was a 39, so the pain level went way down. Not because of the drug, but because of their expectation of the pain level going down, because they thought the drug was there. And then finally, in the fourth condition, the patients were told the drug was discontinued, that it was no longer in them, that it had been flushed out, even though it was still there in the same levels. So sure enough, when asked what their pain level now was, it actually went back to baseline. They reported experiencing just as much pain, even though they had the freaking analgesic there. And we know from the second condition, the analgesic does help. It should be lower, right? Their pain rating should be more like 55. But because they expected the pain level to go back up, because they thought they had flushed out the analgesic, then they experienced more pain. People perceived more pain because they thought they were going to perceive more pain. So a large part of the pain level is determined by our expectations, not the pharmacological effect of the analgesic drug itself here. This is actually a straightforward example of the placebo effect. You're likely familiar with the basic idea. The placebo effect is basically an improvement. In this case, we're talking about less pain, but in the absence of a actual pharmacologically active substance, and the treatment itself doesn't do anything. It's the expectations. It's something about like the way your brain is processing the signal that seems to change. In this case, that causes an improvement. You sometimes hear people describe this as mind over matter, which is not a super accurate way of thinking about it. Because for one, it's more like central nervous system over peripheral nervous system rather than mind over matter. But also the slogan mind over matter can give people the false impression that we can just think our way past everything and heal everything with good thoughts. And that is patently untrue. We've shown that many times that just is not the case. We actually need real medicine and real treatments for lots of things. The area where placebo effect has the most noticeable effect, the most noticeable help, is in pain. And we'll actually see why in the third video in this topic. So we'll come back to that. Meanwhile, though, I want to mention something important here, which is that the same kind of effect of expectations can work in a detrimental way. We can see this with what's called the nocebo effect. So if you expect things to feel worse, they may actually feel worse. So the nocebo effect would be getting worse, in this case, experiencing more pain in the absence of a pharmacologically active substance, or in the absence of something that would actually cause that additional pain. In this case, so it's due mostly to expectations. So one common example we find in research is people actually will experience more side effects from the exact same medication if they're told ahead of time that the medication has those specific side effects. So if they expect that they might have those side effects, they will actually have them more. They'll report them more. They'll say they're suffering more from them. Okay, aside from expectations, pain perception is also influenced by other top-down mechanisms, so like cognitive mechanisms like our current attentional state, or whether we're distracted from the pain by something else. A good anecdotal story demonstrating this comes from Bruce Goldstein's Sensation and Perception textbook. So here's the quote. I'm just going to read through this story. A person had kind of written in and given him this story. I remember being around 5 or 6 years old, the person says, and I was playing Nintendo and my dog ran by and pulled the wire out of the game system. When I got up to plug the wire back in, I stumbled and banged my forehead on the radiator underneath the living room window. I got back up, I staggered over to the Nintendo, I plugged the controller back into the port, thinking nothing of my little fall. As I resumed playing the game, all of a sudden I felt liquid rolling down my forehead, reached my hand up and realized it was blood. I turned and looked in the mirror on the closet door to see a gash running down my forehead with blood pouring from it. All of a sudden, at that point, I screamed out and the pain hit me. My mom came running in and took me to the hospital to get stitches. So, having your attention heavily focused on something else, like the Nintendo game you're in the middle of and the goal you were focused on, that can actually minimize the pain level you would feel from the exact same stimulus. If that gash had happened while the person is not distracted by needing to get back to their game system, then they would have noticed the pain more immediately. It would have been more extreme during those initial moments. So this is actually used to great effect when, for example, pediatric doctors and nurses will often distract a child when giving shots or doing a painful medical procedure. I mean, we also do this for adults as well, but it's really common with kids. I want to show you, in fact, for a while now, some medical centers have been using virtual reality to provide distraction during some really painful procedures, like super excruciating, burn wound treatments and things like that. So I'll show you an example of that from a while ago.
I was on fire. I couldn't see to unbuckle my seatbelt or open the door. I believe my guardian angel just took me out of the truck.
First Lieutenant Samuel Brown survived an attack on his Humvee in southern Afghanistan, but he would then have to endure rounds of surgery, skin grafts, and painful skin stretching.
This is a battle that's going to take years to get back to being how it was prior to this.
But while Brown's body fights that battle, virtual reality technology lets his brain enjoy hurling snowballs to the music of Paul Simon. University of Washington researchers Hunter Hoffman and David Patterson designed the virtual reality game Snow World to occupy burn patients' minds during painful wound cleaning or physical therapy.
Snow World's the opposite of fire. Snowy, cold. It's supposed to cancel out and help distract them from remembering their original injury.
Their previous research showed that not only do patients report less pain in Snow World, MRI scans show it reduces the brain's pain signals. Brown's doctors see real improvement.
What we saw was marked improvement in the range of motion that we were able to achieve, and most importantly, an increased level of comfort.
So indeed, here's some data from a kind of early study with that Snow World game. First off, on the left here, the left graph, this is some data for pain levels during wound care for patients who were given morphine, like one of the usual ways trying to help pain during an extreme procedure like this. So most people, even with morphine, still maxed out on the pain scale at excruciating. So going through that burn wound care was really, really, really painful, even on morphine. But then, okay, that's kind of the earlier control data. Then on the right here, we have some example data from one of the early studies using virtual reality. So it's a different scale here. The pain goes from 0 to 10. Don't try and compare the left and right graphs directly. But the blue bars here are for patients who got VR during their treatment. Notice that the worst pain never got that high on the scale from 0 to 10. And the pain itself the unpleasantness wasn't as extreme. They didn't spend as much time thinking about the pain during the procedure. Their anxiety about it was minimal. And compare that to the control condition in red here, where participants played Nintendo rather than being deeply immersed in something like VR that can really distract you better. In that condition, they felt much less of a sense of presence in the game. So compare here, the Nintendo, you don't feel that much sense of being in the world. In VR, you feel quite a bit more sense of immersion or presence. But their pain levels then with the Nintendo were quite a bit higher, closer to the usual levels we'd expect. So it's something about being really immersed and feeling presence in VR that makes it extra effective at distracting people when they're feeling these extreme amounts of pain. So it's been a promising treatment that there's lots of research still going into. Finally, another good example I wanted to mention of top-down influences on pain, where the pain we experience isn't just a function of how much our nociceptors are firing, comes from our emotions. So for example, studies have shown that when people are just looking at positive pictures that other people in previous studies have rated, or these are universally kind of positive affect, positive emotion pictures, subjects will keep their hands in painfully cold water much longer when looking at those than when looking at negative pictures or neutral pictures. So this is another way that we often study pain in a laboratory. One way of operationalizing pain is just getting some water that's so cold, ice water that's so cold that it's painful to leave your hand in there for very long, and seeing how long people are able to keep their hand in it. Tell them just keep your hand in there as long as you can. Eventually the pain gets overwhelming, people will pull it out. So the question is, it's basically like a way of measuring how much pain someone is in is how long they can keep their hand in that same cold water at where it's kept at a constant temperature. And in this case, people can do that longer, so the pain either isn't as extreme or they're not feeling as much pain when looking at positive pictures. Likewise, though, like I said, we have other ways of testing pain in the laboratory. So sometimes we might do a painful heat stimulus, for example. And likewise, a painful heat stimulus hurts less and is rated as less unpleasant when people are listening to what they consider pleasant music, rather than in control conditions when they're listening to unpleasant music or just silence, like no music at all. So their pain ratings are a fair bit higher, statistically significantly higher than when they're listening to pleasant music, and same with the unpleasant. So the intensity of the pain and the unpleasantness of the pain are better. And if you're curious what the effect size is here, so it's statistically significant, that's why they've got it in bold here, but the effect size is about as strong as taking an ibuprofen. So it's a pretty meaningful, sizable effect size. Now, a good way to summarize some of the stuff we've been talking about actually comes from Ronald Melzack, one of the people who came up with the gait control model, and I'll talk more about him in the next video. But he says, pain is in the brain. Basically, nociceptors firing won't lead to any pain experience at all unless those signals get processed in the brain. Just like turning on your rods and cones in your eye doesn't lead to seeing anything until that signal gets to the brain and gets processed there. But also, the brain itself, we see, has all sorts of influence on whether we feel pain or how much pain we feel. And as we'll see in the next video, the brain can even create pain in places we don't have any nociceptors, in parts of the body that don't even exist.